All right, good afternoon, everybody. Good afternoon. It's a little better. Not quite as engaged and feisty as you were this morning, but I guess the fried chicken and pulled pork barbecue sandwiches will do that to you. I think we should have no trouble keeping people awake during this next session, which I'm really excited about. But first, got to do some logistics, got to do some thank yous. I skipped over some of those during our last session because we were running way over and needed to get out. So let me thank a bunch of our other key sponsors of the meeting this year. At the Emerald level, Anthem, Magellan Healthcare, and United Healthcare Community and State, a United Health Group company. At the Sapphire level, the Blue Cross Blue Shield Association, CareSource, General Dynamics Health Solutions, Hewlett-Packard Enterprise, Maximus, Molina Healthcare, Navigant, Vertex, and Xerox. And then finally, DentaQuest for sponsoring the cell phone recharge lounge right out front. So thank you to all of you. So let me, without much further ado, introduce the moderator of our next super exciting panel. We are doing a very, very high-level, big-picture look at value-based purchasing, and I found the most qualified and engaging person I could get, who is Chris Kohler. He's also one of the tallest people I know, but he is the president of the Milbank Fund, a group that spends a lot of time and energy and intellectual capital in this space and in working with states and state Medicaid agencies, which we very, very much appreciate. And I've actually known Chris for a very long time, from his days as the Rhode Island Health Insurance Commissioner, and for at least a significant portion of that time, he was the nation's only health insurance commissioner, which is kind of an interesting way to think of it. Why don't more people do that? But most states, their insurance commissioner does everything from property and casual to everything else. But he was the only health one. So he is a font of wisdom and knowledge, and I think without much further ado, I am going to turn it over to him to lead a very relaxed, comfy chair discussion with our panelists, whom he will introduce, and then say, everybody, thank you. Come on up. We look forward to the conversation around the future of health purchasing.
We have a assigned seat.
Good afternoon, everybody. We all have to sit up in these chairs because if we sit back, we sink too far. We all look like Edith Ann or something. So I just want to know who, Matt, you've gone through the list of sponsors. I want to know who sponsors you. You know, Matt Salo sponsored by your staff. Well, I'm not sure they would want to own up to it, but thank you for the gift of Matt Salo. So I'm Chris Kohler. We're going to, after talking with Matt, we're going to do this in this kind of casual format. There's going to be no presentation. This is a PowerPoint-free zone. We're going to have some sort of a set of questions that I'm going to ask each of our guests today. I kind of feel like I'm the Joe Madden or Tito Francone on a team of all-stars. You know, fortunately, these guys all have their egos in check, but you kind of wonder how he does it because we've got a really good panel that NAMD has put together for you. So we're going to hear some opening, just sort of level-setting comments from them, and then we've got a set of questions to go back and forth. They've got instructions to ask one another as well as to respond, and hopefully we will have a very interesting conversation around this. So starting from my right, your left, we have Dana Saffron from Blue Cross and Blue Shield of Massachusetts. Jason Helgerson, who's getting a lot of grief for actually attending this meeting. Apparently, can be a little bit mysterious. Patrick Conway from CMMI, and at the far end, Kathy Parsons from CentraCare in Minnesota. So we got providers, we got payers, we got national and local. Teeing this up, I just want to give 3 themes, and then we will go through some opening questions. Value-based payment, I just want to kind of throw out 3 ideas. The first of all is the role of Medicare as a driver. Some people thought that when the ACA was passed, the idea of putting innovation and Medicare was an oxymoron. So together, Patrick has worked hard to belie that. But we have this theme of Medicare trying to throw out payment models. Our conversation today is going to be, is it having an effect? What's the effect of it, and how have other payers, Medicaid and commercial, been responding? The second is I started writing down initials. So PPO, MCO, EHR, HIE, VBP, APM, CCO, ACO, and PCP. How do we know that VBP is not the latest in this march of innovations that have been providing us all full employment for some time? By my combination, if you just go to 3 letters, the good news is that we have 17,576 possible permutations of letters that we can go through for innovations. And are we actually going to stick with VBP and APM, or is it kind of a passing phase? And more seriously, kind of a theme that I want us to keep coming back to is standardization versus variation. What's the right balance between that? In our work with the Milbank Memorial Fund, there's no doubt that Vermont is different from Texas, and they want to be different from one another. There's no doubt that Medicaid is different from Medicare or from commercial. But what is the right balance between consistency among those, particularly when you talk to payers, and what's the right level of variation? That's something that any Medicaid official who's ever gone into negotiations with the feds has to think about. So with those as sort of as themes, let's get into the conversation. I'm just going to go I'm going to start with Patrick as the Fed, and then ask each of these folks just kind of an opening question, and then we'll get into some of the applications of VBP. So Patrick, from the perspective of the Centers for Medicare and Medicaid Innovation as sort of a source of a lot of ideas around payment, in very simplistic terms, I think of what you're doing around primary care, something the fund's been involved in, a whole set of initiatives around bundled payments, accountable care, and then a 4th chunk that I'll call innovation grants, state miles, and stuff like that. What's next? What do you learn? What's next, and what are you learning? And you might want to handle it in the reverse order, but yeah. Give us a sneak preview of what you're going to pop on us next year.
Yeah, so I think a few thoughts first on what we're learning. I think, and actually I'll start with I think we have many payment models, as you alluded to. If you think about our alternative payment models, so population-based models, and CMS, I think about CMS is Medicare, Medicaid, CHIP, and Marketplace, so we try to think across all sectors. I think we're seeing accountable care organizations as a big piece of that puzzle, bundled payment and comprehensive primary care. And I think you're going to see us more iterate. The what next is more going to be the next generation of a number of these models, and then I'll come back to state-based innovation. So I think ACOs now from MSSP Track 1 through Track 3 to next generation. We're also working on a Medicare, Medicaid ACO concept as well still. I think you will have an array of ACO models across the landscape. I think bundles, we've already said, we're working on iteration number 2.0 or whatever branding that we put on it, but what's the next iteration of bundles? We're trying to do a fair amount of work at the state level on what Medicaid bundles could look like, because as you alluded to, Medicaid bundles, some of them may be similar to Medicare bundles, but others may be different for different conditions and disease states in the population. Then comprehensive primary care, I think, is one of our great examples where you really meld it together, commercial, Medicaid, and Medicare at the table, aligned payment model across quality measures, et cetera. And then our state-based innovation and Medicaid Innovation Accelerator program and other things at the state level, this has been a major investment. So if you look back, I've now been leading CMMI for about 4 years and principal deputy for a couple years. State-based innovation when I started was a couple people and not a lot of investment. It's now over $1 billion investment from CMMI and growing. And I think you're going to continue to see it to grow. Some places like Vermont doing things like all-payer ACO, but as you alluded to, I think other states, it may be Medicaid Innovation Accelerator, it may be waivers. I know Vicki Wachino is talking at the end of the conference, but I think increasingly across CMS, we're focused on alternative payment models, delivery system reform, how we weave these pieces together to achieve better care, smarter spending, and lower cost at a faster rate.
Great. Hang on, states especially. Jason, big Medicaid population, big state, the Empire State. You've got your federal partners here innovating like mad. They say they're really interested in what the states are doing. You were early to the game with DSRIP, your delivery system reform project. It's thrown a few dollars around and making some waves in the state. How are you doing with DSRIP? What are some significant past milestones, and where do you think that's going in the future?
Sure. So yes, we are big believers in the need for health system transformation, and I think how we got there was that we began Medicaid transformation back in 2011, and there was things we had to do sort of get our own house in order. There were policies, procedures, programs that really were not structured in ways that would ensure financial sustainability for the program as a whole. And obviously, as everybody in the room knows, Medicaid is so important to not the lifeblood of the healthcare delivery system, but to the lives of real people, millions of them all across our state. And so we had to do things to get our own house in order, and we feel like we've greatly accomplished that. Our per recipient spending is now less than it was in 2000. And we've narrowed the gap between our own per recipient spending, which was among the highest in the country, and the national average, while per recipient spending has gone down particularly since the Affordable Care Act. We've reduced our per recipient spending by twice the national average. So we feel like we're making a lot of progress, but that said, at the end of the day, Medicaid is but one payer of many payers in the healthcare delivery system. And while there are things that we can do to make ourselves more efficient, at the end of the day, if the delivery system itself is not generating the kind of outcomes at the kind of cost that we should all expect as taxpayers, as patients, as individuals, then how much can Medicaid as one payer really do about that? And that was basically the case we made to the federal government around the need for delivery system reform and the need for investment, seed capital, which took the form of DSRIP, which is basically monies to drive the delivery system towards a more cost-effective plane. The scale of our DSRIP program is massive. It's 90,000 participating providers. They've organized themselves into 25, we call performing provider systems, which is kind of like a souped-up version of an ACO in the sense that it's far more inclusive than sort of your traditional healthcare providers. It includes community-based organizations, human service providers, housing providers, local governments, a wide array of entities across the community. It's a statewide initiative. And each of those organizations is attempting to do things to really integrate care, to try to launch initiatives that are value-based or evidence-based that can lead to better outcomes. The goal of our delivery system efforts is a 25% reduction in avoidable hospital use. But also we have a goal that at the end of the day, we will have a different healthcare system than we did when we started. Give you a sense, one of our projects that's being deployed all across the state is the integration of physical and behavioral health. We want to do that across 1,000 clinical settings in New York State. The scale of the integration that's happening in New York has not been tried anywhere that I know of, and it's because we have a significant federal investment. The total value of DSRIP is $7.3 billion. So
Billion.
It's a billion, yes. So it's a very large and ambitious program, but at the end of the day, the funds for this program are temporary. It's a 5-year program. It's not meant to continue on forever. So what we have to do, which is the big thing and obviously relates to this panel, is the move to value-based payment. And CMS wanted, and we agreed, that at the end of the day, the state had to move forward with value-based payment. And we are on a path, in fact, required to achieve that 80% of our $60 billion a year budget has to be value-based by the end of the decade. That's billions and billions of dollars that will switch from one set of financial incentives to a whole different set of incentives. And that means that thousands and thousands of organizations across their state are going to have to change how they operate in order to function, survive, and hopefully thrive in that new environment. And that's a big deal thing, and obviously, we want to work closely with our federal colleagues, particularly Medicare, because between Medicaid and Medicare in New York State, you're talking 50 cents out of every dollar in the healthcare system. And so it's an ambitious effort, but we feel like we're well underway.
Great. So we're going to circle back to some of these themes once we've heard from everybody. Dana, 2 new 3-letter acronyms, FFS and AQC. So we've been talking about lots of folks have been talking about all the lousy economic incentives created by fee-for-service payment systems. Blue Cross and Blue Shield of Mass was out of the box early with its alternative quality contracts. 2009, you implemented it. You've been staying with it. You've been expanding to other product lines. What are you guys learning, and how is it instructive for folks in other parts of the country?
Great, thanks, Chris. So, yeah, in fact, in 3 months, it'll be 10 years since we began developing the alternative quality contract. So February of 2007 was when we started to do this. And I'll just take a moment to say, why? You know, back in 2007, before APM was even an acronym, before ACO was even an acronym, why was it? And the answer is that Blue Cross Massachusetts, living in Massachusetts, we were in the first months of implementing our state's coverage reform law, which of course folks in this room know became the template for the ACA. And we knew that cost was next. And we knew that cost was next because the framers of the law had intentionally not tried to address cost and coverage in one bill. They thought they'd never get it done. But we also knew cost was next because the public would, for the first time, there'd be large numbers of individuals buying insurance for themselves, and they would come face to face with double-digit rates of increases. Sound familiar? Yeah, so we knew that there would be public outrage, really, at why healthcare is so expensive to begin with and goes up so much faster than everything else they buy. So we said our best lever to address that double-digit rate of cost growth, which we'd been seeing in our own claims for a long time looking backwards, was our contracts with our providers. So we wanted those contracts to really do what we called our twin goals, to significantly improve quality and outcomes, while at the same time significantly slowing spending growth. If the triple aim had been out there, we probably would have said our triple aim, but we were lumpers and not splitters, so we said those twin goals. And so what are we learning? So we developed the contract in 2007. It has many of the characteristics that now seem sort of commonplace. At the time, they were brand new. Provider organization agreeing to be accountable for total cost of care for a population from prenatal care to end-of-life care and everything in between. Upside and downside risk. Strong incentives on quality measures where there's earning opportunities, significant earning opportunities on quality and outcomes, and where quality drives the share of savings and deficit. And we started out in 2009 with our first contracts and about a quarter of the network opting in. We now have over 90% of providers in Massachusetts who are contracted in this way. That initial base was, as you started to point out, on our HMO book of business, which is about half of our commercial membership. The other half is PPO. We launched expansion to PPO in January and have roughly half of eligible providers contracted under global budgets now for PPO as well, and more doing that as they renew. So what we're learning is, you know, incentives actually shape healthcare, right? So the delivery system changed enormously. Even in the early years of implementation of this program, prior to CMMI and CMS launching the Medicare ACO program, but particularly since that program launched, you saw almost every large Massachusetts provider opt into it and stay in the Medicare ACO program, including, you know, Pioneer as two-sided risk, because they were already doing this on the commercial side and wanted to, you know, get the proverbial other foot out of the second canoe into the first one. So payment incentives are changing healthcare for sure, and being aligned across our major payers, and we're thrilled that our Medicaid program has just gotten a waiver that's going to allow them to move forward with the similar payment model. So we're kind of well on our way, I think, in Massachusetts to having a fairly aligned approach to provider accountability for total cost of care, quality, and outcomes.
That's quite an aspiration. Keep us informed. It's okay. So, Kathy, Minnesota, land of 10,000 collaboratives.
Yes.
You've got, I'm sure Marie Zimmerman and her colleagues have aspirations just like Jason does around how you ought to take care of the Medicaid folks. You've got Patrick throwing out all sorts of payment reform models. Your commercial guys are coming at you with their ideas of what constitutes value-based payment. You do managed care contracting for your delivery system. Why don't you describe your organization a little bit and what your contracting strategy is in this brave new world of value-based payments and alternative payment models?
Sure. Well, I'll start with you're killing me. And Marie's doing a great job. But our area is north of the Twin Cities, northwest of the Twin Cities, and we are the major provider in the area. There's not a large competing hospital. So one question you might ask is, why do you go down this road of value-based contracting? And the answer is it's the right thing to do, and it took us a long time to come to that answer. It wasn't an easily one answer in the organization, but we started value-based contracting when our commercial payers first came to us at the end of 2011 and said, hey, guess what we want to do in 2012? And we said, oh, we had nothing. We had no infrastructure whatsoever to try and convert our care into a more value-based model. But we said, it's what we need to do. It's where people are going. And so we signed on the dotted line and took a bit of a leap to say, how can we change this? And since then, we've been running full throttle. In 2013, the state of Minnesota and Marie and her team had approached us for 2013 to move into such a model, and we did. We were one of the initial organizations, I think there were 6, that did do this. And it's much easier to live with all in one boat than one foot on the dock and one foot in a very tippy canoe. So for us, it was better to be able to say, yep, we want to go down that road. We want to work with medical assistants and try and get the same incentives. The more you can align incentives for your physicians, the better you're going to be. Now, I say that knowing that there are still some incentives that don't work well together. For example, as we try and reduce cost, we want to convince patients that maybe there are things that we know won't help them that they want done. And if you don't do them, though, that tends to come out in your patient satisfaction surveys, and which one do you do? Because they both matter at the end of the day. So we have been down this road for a number of years. We've re-upped our contracts, and we continue to expand those. And so that's, we came to this area, this space, saying this is what we have to do. Our board of directors is in the community. If we don't change the total cost of care for employers and everyone else, it's on us. We can point to no one else and say it's them. We'll have a board who's saying, well, you expensive provider, what are you doing? So we knew it was time to get on this train, and that's how we got here.
All right, so with that as kind of a setup of where everyone's coming from, I want to talk more about sort of the implications of this world of value-based purchasing. And actually where I want to start off with is with Dana and your experience at Blue Cross of Mass. One tension, because you've been at this the longest, and I got to say, coming from Rhode Island, we're sick and tired of hearing how smart you always are in Massachusetts, and why can't we get along with it? So yeah, I'm still got the chip on my shoulder. But you have been at this for a while, and a tension that I see payers struggling with, I'll get to Patrick in a moment, is are we innovating or are we testing? Are we doing payment reforms and then submitting them to a rigorous test over time, or are we learning and improving and innovating? Or is that just tweaking because we're impatient and we always think we don't wait around to get results? So from Blue Cross's standpoint, how do you find that balance between steadiness so you can evaluate and innovating so you can improve?
Well, it's an important question, and very closely tied to the question I know we're going to get to around alignment. So are we, how far do we go towards standardizing? But, I would say that we have had to continue learning as we go and improving on our model. So using the definitions that you've just offered, Chris, I'd say we're innovating, and we have to, because we're too early in all of this learning to lock down on a single model and say, let's just keep testing this so we can have a pure experiment and know exactly what worked and what didn't work. So we are testing as we innovate to blend those two words. And we've been fortunate because from the very first year of the AQC, we've had the Harvard Medical School team that's been doing a formal year-by-year evaluation of what we're doing. And it's been challenging for them, right? Because we haven't had one model. In 2011, we made some pretty important changes to the way the model works. And then we stuck with that for a while. And we do keep changing it. But one thing that's been important and really different for a local payer compared with what Patrick's programs will do is we haven't tailored this provider by provider. We treat it as a program, and this is how it works. And if you want to participate, you'll participate in the program designed like this. That's made a very important difference in the way we can do this work and the way we can evaluate the results, I'd say.
What's it been like for you at CMMI? They said, you have a pretty rigorous standard that you've got to meet, imposed on you by Congress from the Office of the Actuary. And does that mean that you can't tweak, you can't adjust, because you got to keep it solid?
Yeah, we are also innovating and changing the model. And actually, I'm going to separate payment and care delivery a little bit here, because on the payment models, we are innovating and actually will change during the model. So Pioneer ACO, we changed multiple times. We do have a high bar in actuarial certification in terms of savings, but they look at the totality of evidence and actually project the likelihood of savings in the future based on our evaluation. But Pioneer changed frequently, bundles, same, comprehensive primary care has had changes. And I want to be clear on payment versus care delivery. And what I mean there is there's in reality only so many different payment models in the world, and I think sometimes we argue too much about the exact details of some of them. Whereas care delivery, the providers are, I used to be on the provider side leading innovation and still practice as a physician. You want care delivery innovation. We don't want to mandate all the specifics of how care coordination happens or care delivery. And that innovation, we're seeing our ACOs, our bundles, our states. I mean, we want innovation within a payment framework that drives to the same goals. And I think that, whether it's at the state level or at a provider organization, that type of innovation in care delivery is exactly what we would want and really is part of the continuous learning cycle.
Yeah, but because I'll just change my standards for the patient-centered medical home, and that doesn't that amount to if I say no, you've got to do a CAP survey every year. I'm sorry, that's the new improvement that we put in. Isn't that changing the payment model? Yeah, that's a care delivery, or you've got to hire this, do this kind of.
I'll parse a little bit, and others push back. I think for comprehensive primary care initiative, I think, and now CPC Plus, I think aligning on quality measures of which CAPS was one was important, because then it was 13 quality measures, the same across payers. And I think what we heard from providers and others was that was critically important. So I think, but I'd still put that, there's model components where you may align on big pieces, such as the basic financial model, risk adjustment, quality measures, et cetera. Then underneath that model, whether it's comprehensive primary care or state innovation, I think we want people to innovate on how am I going to get that outcome. I think where you get in trouble is when you mandate the process. I think then you can stamp out innovation and lower the sort of learning cycle.
Okay. So before we get into this issue of alignment, I want to talk about value-based payment as it applies to Medicaid in particular. So Jason, just objectively, and then the philosophy behind it, how much does your roadmap differ from the options that Medicare is putting out there, and how much of those differences driven because Medicaid populations need something different?
It differs in the sense that we went into value-based payment with an explicit policy decision not to score any savings from the move to value-based payment. Our objective is that all the savings, we have a global spending cap we have to live within that grows at the medical portion CPI that's across the total program. But we didn't go in with some artificial savings amount or target for ourselves or for providers. There are no haircuts. There are no built into our models. The idea being that we really want value-based payment to be about aligning incentives around improving health outcomes. Yes, they will help us be sustainable in the long run, But I think that's first and foremost a little bit different between how it's structured from Medicare at the federal level. Are there differences? Yes, we have tried very hard in our approach, and New York's a big to align with particularly with Medicare, and as new models have come out, particularly around performance measurement. And the populations have similarities, but there are important differences. Obviously, the maternity care bundle and maternity care set of services extremely important to Medicaid. Why 50% of all babies delivered in New York State are delivered while they and their parents are on the Medicaid program. So it's extremely important that we get that particular set of services right, and obviously it's not a real big priority for the Medicare program. But I think to the extent to which where there are areas of overlap, I think particularly alignment around the measures has been important. We've had a very robust stakeholder engagement process around measures. 600 plus individuals ranging from frontline clinicians to national experts, patient representatives who have helped us in clinical advisory groups across the spectrum, looking at specific different models of value-based payment and subpopulations and different bundles to come up with what's the right measure set. But as we've done that, we've always tried to make clear is that we don't want to add more complexity by having slightly different versions of the same measures. But the last thing I'd say about this, and one difference, although the Medicare population includes subsets of the people I'm going to talk about, but for the Medicaid population in particular, the social determinants of health are so essential. And one thing we've heard loud and clear from our stakeholders is a desire to begin to hold providers accountable around measures associated with social determinants. Going beyond the traditional HEDIS set of metrics to start thinking about things like housing and employment and start to integrate those into the measure sets we use, that when yes, you can generate shared savings, but it always has to be about also improving outcomes and including some of those outcome measures. Now that may be a little bit, it's not something you're going to see typically in the commercial world, but it's really, really important in Medicaid, and that I think is where you are going to see a little bit of difference, is that you'll see Medicaid, I hope at least nationally, you'll see Medicaid programs trying to push the envelope on how we measure those social determinants and making that the improved performance in those a driver of payment.
How's that sound to you, Kathy? You ready to take on responsibility for kindergarten readiness? Should we put it into our contract standards for you?
Actually, we are very interested in that. We have been very busy trying to think through the social determinants of medicine and how we can partner with people to get there. What can we do to find ways to improve those types of services? So while we haven't made it to kindergarten readiness, we have packed up our entire executive group on a bus and driven around the city to find those food deserts and say, okay, what are we going to do about them? We have worked hard to improve or decrease the rates of childhood obesity. And in fact, through a project we've been working on, depending on the age group, we've reduced childhood obesity in our area by anywhere from 20 to 28% over a few years by working with schools, because we're going to find our biggest changes we've found by getting to kids, which means we have to work with the schools and get to the kids who often change parents. We've worked with the local grocery stores who help do that. So we're interested. One of the barriers we run into, though, is in our work with social services is how do we share information, and what are the barriers to actually being able to say, hey, here's what we got going on, here's what you got going on related to specific patients. You can't get to that level. So those are things that I think would help us to make some different changes, but we firmly believe that the social determinants are important. We're working on, how do we improve sidewalks to school so that kids get a little more exercise and that type of thing.
So I want to make sure I know the antecedent here. I'll go back to my grammar school lessons. It reminds me of the conversation this morning about opioids. When you say we, who's the we?
So we a lot of it is driven by Centricare Health, but we have pulled in major employers in town. We've pulled in all the folks we think we can. In fact, there's a city group that works on this to try and say, what can we together do? What can we identify? Where can we tackle? Where can't we tackle? So I don't think we like to think of ourselves as fully responsible for it, but we do believe we're a critical player in it because our physicians frequently know what's going on. They hear from families. They see when those patients come in what's happening. So for example, we know that patients late in the month, when they have less access to food, we see a higher increase in people who are admitted to the hospital with diabetes complications. So we are working with Second Harvest. In fact, we got a grant from the state to work with Second Harvest, which is a food group who are putting diabetic packages in the clinic so we can give them out to patients. So we see ourselves as a critical player, not the only player, and perhaps not ultimately the final responsibility, but understand that the connection and the connection to payment to give us that incentive is really important.
Well, that's Dana's got, she and I were talking about this before, but I just want, would you agree with Jason that even before payment, start with measurement? You know, that as a way to think about accountability, you don't necessarily have to pay you to have kindergarten readiness, but if we're at least prioritizing that as a measure.
Absolutely. I would agree with that. The measurement is really important, and I know that we are all deep into data. We are all, it's the Full Employment Act for data, because we all need it. Big data is hard to come by. Measurement is critical, so yes.
As long as it's my measure.
Right.
Dana, what's
So this is such an important and exciting part of the conversation, because when we talk about value-based payment, the value we are talking about is health. And so this is a first, right, to have the delivery system actually paying for and creating accountability around the production of health as opposed to the production of services that we all hope will lead to health. And so just to share a little bit of our experience in this space, of course, we're a commercial payer, so a relatively, but not completely advantaged population that has insurance mostly through employers. However, we do have a segment of our commercially insured population that are quite low socioeconomic status. And what we saw in the early years and still in the AQC is that the providers for that group of patients were able to achieve outcomes, meaning health outcomes, not just results on the clinical process measures, you know, getting the right things done when the patient's in the care setting, but actually taking accountability and being successful for helping those patients have good control for their hypertension, for their diabetes, for their cardiovascular disease. Those outcome measures are things where you have to think outside the clinical box to where the patient lives and works, and what the barriers are to keeping those conditions under good control. So we saw two of our organizations that serve particularly low socioeconomic populations move forward from a position where they were lagging behind the whole rest of the network on those measures to where they were at the top of the pile, doing better than organizations serving advantaged populations in their ability to keep those conditions under good control. At the same time that nationally, you know, we just weren't seeing the data move at all. So they had to engage with the social determinants of health, but what I would also say is there's still a long distance to go, and what we're seeing now and what I'm quite excited about is those providers want to now figure out how do they partner even more deeply with some of the types of community organizations, the schools, the churches, barbershops, you know, really partnering with community organizations in some of the ways that Kathy's talking about to go the next distance in creating health in the population.
Could I just piggyback on that? Because you asked me about future and I didn't totally answer it earlier. 3 areas I would call out additionally that relate to the conversation we had. One is on social determinants. I think that'll be an increasing focus. I mean, CMS is about through the accountable health communities to invest, you know, over $140 million in 44 communities directly on linking social determinants health in the clinical care delivery system. Certainly focus on social determinants health that's huge in Medicaid, and we will continue to invest in. Second area I'd call out, which was mentioned, mental and behavioral health, and including substance use. And you guys know this. I know you talked about it earlier on the agenda. You got zip codes that life expectancy in the first time in U.S. history is going down. So I think you will see us from CMS be willing to partner and invest in major ways, whether that's Medicaid, CMMI, or others. And I said in a meeting earlier today internally, I am concerned. I think piecemeal trying to fix this will not do it. we are trending in a negative direction as a nation, and it's going to need a multifactorial set of interventions that we, I know many people are working on, but I think we're going to have to accelerate our efforts. And the third area I'll call out is, and this isn't just because I'm a pediatrician, I think there's still real opportunities in whether you call 0 to 5 or 0 to 3, but the sort of younger age, early childhood wellness and health trajectories. I think there's investments we could make there, both certainly from CMS, but across the board. They'll have major long-term health impacts, most importantly, but also lower costs, not just in healthcare, but across our systems.
So let's, before we move off the social determinants, since you brought it up, it's February of next year. You've been brought in to brief the new Secretary of Health and Human Services, whoever he or she may be. From the value-based payment, let's try to narrow it down at least to that part when we're talking about the social determinants of health. What can he or she do to multiply the ability of the feds to help in the local communities? This work has to happen in the local communities. There are good folks working at Medicaid, good folks working at CMMI, but you got good folks at HRSA, you got good folks at CDC, SAMHSA. What can that person do?
So first of all, I'm glad they haven't fired me, so I'm still there. So that's point number one, excited. Hard for me to even get past that. But, no, but in all seriousness,
many are called, few are chosen, Patrick.
In all seriousness, I mean, literally the discussion today was with the head of HRSA, the head of SAMHSA, like the various, ARC, CDC, et cetera. I think there's an opportunity across the federal government, which is always challenging, the classic coordinate across the silos in the federal government and how that links well into states, and others should comment on this. I think we have an opportunity to continue to evolve and do that much better, and I think it's bidirectional in terms of that improvement opportunity. I think it's pulling all the federal levers, and I think you are, like all things, we're gonna have to identify what are the key set of issues. And what's the key set of, I think on alternative payment models, we actually have a pretty good sort of defining framework that's reasonable that the Learning in Action Network came up with. But then underneath that is all the detail about how do you implement, how do you learn rapidly, what are the key sort of care delivery interventions. And there, I think, both on the federal, state, and local community side, we'll need to focus. The last thing I'll say, sorry, a little bit longer answer maybe than you wanted, but this state focus, I think you are seeing, and community focus, I think, is increasing rapidly at CMS across the board, not just in our Medicaid center, but across the board. And I think will continue to increase. And I will try to help that focus on state and local intervention continue to increase.
All right, let's try to get down a little bit back into the world of value-based payment. Jason, and then maybe Dana might have some of this. If you've got a provider who's really into value-based payment and accountable care, what do you need a managed care organization for anymore?
Well, I actually get this question all the time because through our delivery system reform effort, we're creating, as I said, these performing provider systems, and there's 25 of them across the state. And one of the requirements is that they either, as an entity who wants to contract themselves, or what actually is more common as an entity to support other groups of providers within their PPS to move the collective whole towards value-based payment in line with the timelines that we've agreed to with CMS. And people ask, well, if you're doing all this to create this infrastructure, Jason, why do you need the plans? And my response to that is that New York State is a very large and diverse state. We have the largest city in the country. We also have some of the most rural parts of the country and everything in between. And in a state as large as that, and as diverse as that, the challenge we have is what typically would happen if we try to administer the program ourselves is we'd sort of be forced into a one-size-fits-all approach to value-based payment, which we just don't think would work. At the end of the day, value-based payment needs to be tailored to the unique needs of the community. Each community has assets, each community has challenges, and the concern we had centrally was that if we tried to manage that on a whole, potentially thousands of contracts, that we would, as a bureaucracy, not be able to effectively do that. So at the end of the day, our belief is that the health plans that we contract with are in much better position. We hold them accountable. We give them and the providers some flexibility. We have a roadmap that says here is a menu of choices. you're required to move into these value-based arrangements. We need to show progress. We use the health plans as our vehicle for driving that. But at the end of the day, we know that the way the program needs to be structured in the Adirondacks is going to be different than it's going to be structured in the South Bronx. And that's just the nature and the reality of our system. Our sister state to the east, Vermont, it's a different scale, different situation, and I think they have an ability there, given their size, to do something that's more on a statewide, a little bit more of a standardized fashion. But I think you got to the point, which is that in every state and every payer, I think, is in this situation, which is, we call them standards versus guidelines. How much do we mandate, require, standardize, versus how much do we give providers flexibility? And that's a line we constantly walk. But as long as we are allowing that flexibility, which I think is what's needed in a state as large and as diverse as New York, we think that the plans are in better position to be able to utilize that flexibility effectively than we would be able to do on a statewide basis.
And Dana, how has the job of Blue Cross and Blue Shield of Mass changed as you've gotten into these value-based payment arrangements? What do you have to do? What are you no longer doing, and what do you have to do that you didn't do before?
Yeah, it's a perfect question. So one of the things that health plans were doing and are still doing in most of the country, though I would argue that even in our own case, we never did as well as any provider organization can do, is medical management, right? So back in the 1990s, employers really looked to health plans to develop population management capabilities, because in a fee-for-service incentive system, providers just weren't doing it. You know, when you're paid by the piece, then you take care of each piece and then your job is done. And who's looking after the whole? But now we've created a payment model where the provider is looking after the whole and is building up the population management infrastructure to be able to do that quite effectively. New staffing models, new uses of data and information systems, new relationships within and across care settings. And so one of the things that we're doing is actually backing off of our medical management programs and formally delegating these to providers. Now, that's relatively simple between us and our provider partners, because they would rather do it and we would rather have them do it. Where it is complicated is that some of the external players still have expectations of health plans doing it. Some of the accrediting agencies expect health plans to have these functions, and they're starting to create programs that make allowances for it, but it's complicated because you've got some plans in parts of the country that aren't doing this at all yet, and others in our market where I think we're farthest along. But even more important than the accreditors are the employers and the consultants who serve them, who really want kind of one way of doing this. And if most of the country still has the health plans doing it, it's complex. Talk about, standardizing versus guidelines. It's complex for them. If they have a market or a plan within a market that is allowing providers to do it, it's hard to kind of spreadsheet that or check the box that, you're doing it in a way that the consultant understands. So that's one of the barriers to moving in this direction, but that's one of the biggest changes, is we're backing off of some of the functions that don't make sense for us to do. The provider has the clinical relationship, and now they have the incentive to manage total cost of care. They should be doing it. And I'll stop there. I know you asked me, what are we doing that we weren't doing, but I don't want to take too much time.
But Kathy, if you guys are taking on more of those responsibilities, why don't you just become an insurance company? Why don't you've got the population, you're seeing them every day. Are we back to the future with staff model HMOs?
We could be. Depends. Now, we don't have the financial resources for some to be an insurance company. That's probably not going to happen in enough markets or enough providers who would have that capability. But I do think there can be an argument, particularly in the Medicaid area where you mentioned, why have managed Medicaid organizations. I think that's specific to the state and the community, but I think we'd just as soon not have them, because every health plan uses a different data analytics platform. We have to go sign into different places to find out what data we got, who's doing what. And we're never going to get physicians to do that. So for us, it would be easier to say there's one. Here it is, and here's how we're going to go. So I think that providers are starting some of those conversations. In fact, I don't think it. I know that they're starting those conversations. Not all of them will ever be able to do that. Most won't. But I think that there is a question about it, is what role, or what is, redefining what the role is. You know, insurance is insurance.
Right.
And that's not what we are. So how do we define that role better and really divide up who's doing what, whose role is it to do what, and then being clear about it and moving forward from that. You know, we all need each other to succeed. I think Medicare wants providers to succeed, Medicaid wants providers to succeed, insurers want providers. We all want to succeed, and we need each other too. So it's really a matter of laying our cards on the table. What really does it take to succeed? What does that look like? And trying to avoid but who wants the money? Because that, in the end, it's always about the money. And how do you separate those out and say, what really can we do?
Okay, we're now dancing around the alignment question. I want to approach it first from the perspective of Medicaid and then from the payer perspective. So here's your chance, Patrick. You've got all the states here. They're all trying to do some version of value-based payment. I'm telling you, I've got a patient-centered health homes program. It's different from a patient-centered medical home program. So you have to approve my particular way because I've got some really neat things that I've worked out with my providers. How many flowers do we need to have here? Are we talking 1,000? Talking about one?
Set me up.
No, I mean, what's the right, this is this balance, and I'm talking about specifically from Medicaid standpoint.
Yeah, so I'm going to first frame this in the way we have discussions with both commercial and Medicare Advantage, and then lean into state and Medicaid, if that's okay.
Sure.
So for Medicare Advantage and commercial, the discussion we have is, you know, if there's actually some new payment model that we don't have that you need, let us know and we'll have a discussion. But there's a reality that we now, if you think about, let's take ACOs and then primary care medical homes. MSSP track 1, one-sided risk. Track 3 is essentially pioneer scaled. Next gen's full risk. We may have a slight gap with a Medicare Medicaid option, which we've talked to some states, including some on the stage about. But we've got a basically array of options. And I think much of the things that people argue about are tweaks on the same vein. And to be honest, as I've been on the provider side, if it's not 100% aligned, it's probably okay. But if it's 80, 90+% of the way there, it gets you there. And I think a lot of times we argue on the edges of things that are arguably not very important. Similar primary care medical homes, I mean, you could design 49 different flavors if you want to. But I think there's a reality. I think there's a lack of evidence that a various special sauce flavor is going to make that much difference on the payment model. Once again, CPC on the payment model, CPC Plus now, you know, we're all putting in population payments, same quality measures, same basic, you know, total cost of care framework. Then if people want to innovate on how much payment and what are the secret sauce they want to put on top, you know, fine, great. And that's the exact same conversation we have commercial. I'll tell you, commercial now, because I've been doing this 6 years, commercial and Medicare Advantage increasingly just matches traditional Medicare. Because actually they've done the calculus of, I've got a provider that's already in whatever contract. If I match it, they'll move quicker. I know Dana's going to argue, and she's the innovator on the stage who might say, you know, and there probably are some instances where maybe you don't want to match totally. But I think we are seeing increasingly large commercial payer that just matched across all their markets. ACOs, bundles, primary care medical homes, both in the Medicare space and commercial. We are seeing that again and again and again. I think we should see it in the Medicaid space. I will make a comment on health plans. A Medicaid health plan that takes a capitated payment and just turns around and pays fee-for-service at poor rates to save money isn't what I know Jason wants or any of us want. A Medicaid health plan that actually partners with the provider, you know, is in these payment models, is feeding data that actually helps, you know, has care coordination that integrates well, that's what we want across the board. So we have aligned goals, I agree, across provider, Medicaid, commercial, and then it's, you know, how do you put that into place? Take the 80-20 rule or whatever analogy you want to use and move forward, and then everybody can innovate in the exact care delivery model, et cetera. But I think the basic payment framework and payment models, I think, could be standardized and adopted, you know, 80% of the time.
Do you guys agree that we're that close in terms of standardized payment models?
Yeah, I guess I agree that there's not as much variation as people think there is. I think at the end of the day, that the difference is, as I say, I think the area where you want alignment to be as close as possible is particularly around performance metrics. To have slightly different ways of measuring pretty much exactly the same thing doesn't add a lot of value. Now, we tend to migrate back to what we know and what has been tested and is tried and true, and a lot of that's HEDIS. But I think that the issues become is that when you talk to folks, particularly those who deal with folks who have the most challenging needs, the ones who really generate the most cost in the system, the ones for whom the system today fails the most frequent, those measures that we use aren't necessarily the best. I think it's a challenge out to the broader world, including folks in this room who think very seriously about measurement in health, is that I would say one area in particular is behavioral health. You look at the typical measure set for behavioral health, and it's something really bad happened, and now it's, can we get them in to see someone within 7 days? Well, that's important. That can't be the only thing that we're looking at relative to that population. And I think we're going to have to be pushing the envelope in terms of making sure, because at the end of the day, my one worry with value-based payment is if we measure the wrong things, we aren't measuring what's really important, and we measure it effectively, the payment incentives will change behavior. But what we don't want is providers to begin to change behavior in ways that are inconsistent with our ultimate goals. And that's why I think we got to have eyes wide open, understand the limitations of the measure sets that we have available, seek to do better, seek to develop new and innovative ways, and to the extent possible, align the sets of measures we use across as many payers for whom it's appropriate.
So Jason and Patrick had described a world where we're really not all that far apart on payment. There's some basic models out there. There's some, you can put sprinkles on it or whipped cream or whatever, but it's pretty much the same. And we got to keep our eyes on measurement. Is that how it's playing out in the delivery system, or is it not all quite so rosy there?
It's not quite so rosy. It's getting rosier.
That's pretty good.
When we started, we had probably 60 different quality measures. By the time we were done with all of our quality or all of our value-based contracts, you can't pay attention to 60 different ones. It's not possible. So we had to pick and say, all right, these are the ones we're going to do. This is where we think we'll have the most impact both on patients but also on our own income, because in the end, we can't ignore that. We have to still have an income or we don't have physicians, and then you don't have physicians. We're in a shortage area, for example, for behavioral health folks, and we have a lot of them, but we still are in a shortage area. Well, we need to have the income such that we can, get them and retain them. So I would say that on the quality side, we're getting there. And with some differences that are understandable based on the populations. I think that on the payment model, they're moving in a similar direction. They're not hugely disparate, but they are difficult to measure, to say what's coming. You want to drive accountants nuts, try and give them this information and say, here's what we think is happening this year. So we're not there on the payment models yet. There's a lot of differences, and I think the other piece that's different is the rules behind the rules. So we might do something that says, yep, this is the direction we're supposed to go, but each health plan has a different rule about, is that covered, is that not covered, when is it covered only if? And once you start to run into those things, we know we're going to provide services that are not covered. We know that that's part of this. But we can't have that everywhere, and we can't have different incentives for different people with different payment sources.
Can I comment on this, Chris?
Sure.
Yeah. So, because I think what you're hearing here is what I see playing out in our market and nationally, and that is there are those of us, and here I'll agree with the way Patrick characterizes it, that says as long as we are aligned on the sort of broad structural aspects of a payment model, that's good. And in fact, I'd go a step further to say we don't want to be farther down towards standardization because we're still, as we talked about earlier, in learning mode. We can't hope to move in lockstep. So aligning on the broad structural things like accountability for total cost of care with risk, maybe we even align and say there has to be some amount of downside risk. That I think we agree on. But what you hear provider organizations experience, and what I think we just heard from Kathy, is that actually until you're all the way aligned down to the nitty-gritty details, to like, it's not just similar measure sets that you've drawn from, but the same measures that you're using, maybe even with the same performance targets, maybe even with the same benefit design for everybody. So we're nowhere near that level of alignment, and I would say that that's the disconnect I hear, because I think from a provider's perspective, they're really looking for alignment to that extent. And the other important variable that we haven't named that I think is useful to get out on the table here is what we're talking about on this podium right now is the incentives that a payer gives to a provider organization. How that organization passes incentives down to its clinicians on the front line is a totally different matter.
Right.
And so part of what I struggle with when I think about this alignment conversation is, even if we went all the way to that extreme that we were just talking about and tried to make sure we had the same risk adjustment model and the same performance targets, et cetera, that actually doesn't guarantee us by any means that the provider down on the front lines is going to experience alignment, because how its organization is feeding incentives down to the front lines could be different. Or on the other hand, we could still be doing things differently and they can actually align and pass things down to the front lines, as I've seen many providers in my market do, in a way that, because the broad structural elements of the payment models are the same across payers, I can now feed a unified set of incentives regardless of payer to my frontline clinicians. That's, I think, a pretty good place to be.
So let's push this alignment issue a bit more. He's got, apart from Medicare Advantage, he's got to put all of his laundry out there, exactly his payment methodology, the whole thing. It's the full Monty. And then
That's true.
that's true. Sorry for the image. Let's just limit it there.
I'm sorry for you.
Jason might sometimes, he has to do that for fee for service to varying degrees in managed care. Sometimes he doesn't want to know what they're doing because that gives him plausible deniability, but other times he wants to know for just the reason that Patrick said. But your colleagues see it as a source of competitive differentiation. They think that Kathy's group's going to love them more because they're somehow got a better provider contract. So we have this disconnect. What's the role of transparency in learning? I guess that's what I'm asking.
I think in our market we've seen a very important role for transparency in learning. So I don't think there's a lot of secrets in how, in our market anyway, provider contracts are structured, because it's all pretty much out there, transparently exposed, the extent to which, a global budget contract, what are the performance measures that are included, even, we've been very transparent about what are the performance targets, how much is tied to that.
Do you have gag clauses in your provider contracts?
No.
Is that by choice or by
Yeah.
law?
That's by choice. Yeah.
I think the thing is that one of the questions I've asked myself sometimes is, so healthcare in the United States is an interesting animal, roughly in terms of, and we talk about it as sometimes, especially in the United States, and I've spent some time in England, and I'm actually flying this afternoon to Canada to give a speech tomorrow. So I'm looking at other countries, and we always tend to focus on differences about single payer versus multi-payer. And we, in the United States, obviously in a multi-payer environment. And so then you get down to is that, okay, based upon what, how does our market function? What in essence are people competing around? And I think that my view of the market in the past was that insurers always were competing based on the price they could charge, particularly in the commercial world. How low could they keep their prices so that they could basically sell insurance products and maximize their market share? And they would battle royale with the providers in their networks to try to keep the costs as low as possible and do a variety of different things to do that. And I think there were a lot of unintended consequences, and a lot of that sort of competition wasn't necessarily connected to better health outcomes for the community or the individuals enrolled in the insurance products. I think what value-based payment gives us an opportunity to do is to actually create a different kind of value proposition, a different kind of competition, where payers, along with their networks, actually see each other not as adversaries, but actually as partners. And what they're offering, in essence, to the market, to public payers like Medicaid and Medicare, or to commercial payers, is a value proposition that's much more aligned with better outcomes for the population and for the individuals who enroll in those insurance products. I think, to me, it's the last best hope for insurance and the concept of a multi-payer environment in the United States. Because I think at the end of the day, if we can't find a way to control the overall growth of healthcare, and I think our best option is the move to value-based payment and trying to create this competition for ever better value and outcomes to the population, if we can't make this work, like, what's next? What's plan B, right? I mean, we can't afford double-digit insurance rates forever. I mean, we're at 17% of GDP in terms of total healthcare expenditures. We need the delivery system to be more cost-effective, and we need to align the incentives between the payers and the providers around value. That's, in essence, what value-based payment to me is all about. It is hard, it is complex, and it's always going to be hard because there's so many different payers in our environment. But I think that our collective responsibility over the next 3 to 5 years is to try to find ways to generate models that can be replicated and to try to work our way through some of this complexity, because I think the stakes are high. I mean, I think the economy has gotten to the point where it's a saturation point. It can only afford to go so much and so much higher. And my fear is if we don't get this right, as I say, in the next 3 to 5 years, and that's going to be a major challenge for the next incoming administration, is how do we get cost-effective healthcare in the United States? Because otherwise, my fear is a slow erosion. Slowly but surely, the quality of care degrades. Maybe in some places, it's such a big degrade that people see it and feel it immediately because a healthcare provider and a system tips over, and all of a sudden we have a healthcare desert. But I fear in many other communities, it's going to be a slow erosion where people are just going to come to accept that the quality of care that they get, the access to care that they get, becomes poorer and poorer. And I think that's the future state we want to avoid. And I feel I'm actually bullish about it because I think there's a lot of smart people in this room and all across American healthcare. We got a big task ahead of us, but I think that we got to really galvanize efforts and focus our research, our efforts, and the smartest people in our industry around trying to make value-based payment a positive reality across the United States.
All right, we'll hop on that hobby horse, but is transparency necessary to do that, to climb this mountain?
So
That's what I'm asking.
I think some transparency, yes. I think, however, that if the world becomes so completely transparent in the sense that negotiations are no longer, my fear is you stifle innovation. I think there is some advantage to allowing payers and providers, as long as you create the right set of incentives for them to want to innovate in the right ways, allowing there to be some advantage to them for some period of time of that innovation, the success of their effort. I think because my one fear, and it's that you get into an environment where there is no incentive for providers and payers to innovate, the risk we run is that we will become stagnant. We will not advance. And the challenge, why healthcare is so hard and so complex, is that we are not talking about a static good. Science continues to advance. There are new and ever-changing ways in which healthcare is going to be provided, and I fear if our payment environment becomes stagnant, if we aren't looking at new and better ways to use the advances in technology in creative ways, I think we're going to miss out on things, and I do fear at the end of the day we won't achieve the full goals of what VBP could be. So
how does this play out for you? And on the one hand, you want alignment, but you're also the only game in town, so you can kind of call the shots.
Well, you're right, we can. But again, as I said before, we don't believe that we really can. I mean, in theory we can, but we don't believe we really can.
I believe in your virtue, but maybe not the person who comes after you. So we need to trust but verify here.
You sound like a payer. I agree that the right incentives need to be there, but most providers also believe that this game runs out, that eventually there's no more cost savings to share. And then what? That the economics eventually get to a point where there's no additional money to be made. Every provider is investing a tremendous amount of money in all the infrastructure that goes towards value-based care. There's a lot of spend going on right now trying to make those changes. So in fact, if you want to, costs in healthcare are a funny thing. There's cost to produce healthcare, there's the cost of covering healthcare, there's out-of-pocket costs for patients. And when we start talking about cost, the cost of what we're using to produce healthcare is going up while our reimbursement is changing dramatically. So one of the things all providers are struggling with, and if you talk to some of the provider healthcare futurist type people, they'll tell you there's an end game here that doesn't work, that we have to now start to think about that next level of end game. And that's where all of the providers are really struggling if they're already in value-based care. Those who are not there yet maybe are still struggling with how to get going. But for those of us who are already in it, we're thinking, boy, there comes a point where this gets difficult.
Yeah.
Can I comment on that, Chris?
Yeah.
So I totally agree that, that's the conversation that is starting to percolate. I think we are so far away from hitting that point where we have taken the waste out of the system. Let me just share a few examples, right? So if we take as a given that there's a lot of evidence that roughly a third of what we do is really not adding value, what we've been doing so far is slowing the rate of growth in healthcare spending. We haven't actually reduced healthcare spending. We've slowed the rate of growth, and we have taken some wasteful things that happen out. We've avoided some readmissions and so forth. We still have a third of our spend, I'm not sure if it's a third of Patrick's spend, that's on inpatient care. A lot of docs I know that say that, we could, if we want, basically get rid of medical beds in hospitals and have, hospitals just for emergency rooms and ICUs and maternity care. So we're, I think, still quite a long way from doing the deep innovations that we could do to get the waste out of the system. So I think we can still compete on our ability to do that for some years to come.
Yeah, can I just add on that? Our Medicaid managed care program, which has been around for a couple of decades, NCQA ranked it second best only to Massachusetts in terms of overall outcomes. The differences between our commercial and our Medicaid managed care plans in terms of key metrics is almost non-existent, and we've shown improvements each and every year for a long period of time. But what I would say is that the challenge is that where we are is that when we looked at avoidable costs in total cost for serving children with asthma in our program, what we found, which I think was shocking to some people, was roughly a third of the total expenditures. This was based on 2014 data. A third of total money spent for kids with asthma was in fact preventable. And that to me is an example. That means that there are kids in New York who are sicker than they should be, are in the hospital more frequently than they should be, and that's an opportunity. That's savings that's better outcomes, and I think as you look across, some providers amazingly cost effective, but there's a whole lot of providers all across this country where the outcomes are not what we would want, and I think that's really, we call it bad variation, where it's bad outcomes at high cost, and we should focus on that. And I think if we focus our VBP efforts there, I think we could achieve the triple aim, and I agree 100% with you that we're a ways away from, I look forward to the day where we have squeezed all the inefficiency out, and we're now really talking about the fact that costs are growing for totally 100% legitimate reasons.
Well,
And I agree with you. It's a ways away, but we're looking at a 25, 30-year horizon as we're doing our planning. But I agree with you. There's still a lot to be done.
and if I were Patrick, I'd say, bingo, I've got success. I've generated a different conversation I had before. But just, you've heard the line, your expense is my revenue. These resources are really lumpy. Hospitals might have a different view about you, I'll channel a hospital administrator. I just can't take out beds and expect to save that portion of costs. I got a lot of fixed costs that I gotta cover. So I've been given the 5-minute sign. We're gonna do one question, then a quick lightning round. Last question is, data in a value-based payment world. What I like about fee-for-service is, yes, it was a full employment act for coders, but I knew what was being provided when. Value-based payment, I got a lot of money that's flowing to you, and I don't know what it's for. I'm paying you for infrastructure payments. I'm paying you some bonus payments on the back end. We're finishing a study trying to measure the portion of money that goes to primary care. 25% of it is going out in non-claims basis, and we don't quite know what that is. What does administrative accountability look like if we're just writing you checks for your quality measures?
Well, I'd say that the insurance company probably didn't do their job. We're not getting that kind of money. We're innovating mostly on our dime, with a few smaller exceptions. But I think that there has to be clear accountability. What are you doing? What has happened? And where are those changes happening? One of the interesting things that on the Medicaid side in Minnesota is we get pulled together by the state, a group together of all those folks who are involved in it and talk about what have you been doing and how did it work so we can, A, learn from each other, but the state group is present there to hear what are we doing, what are the changes that are happening, so that they can kind of have some sense of it. But you're right, we have to be transparent. What are we using this money for? And I think thus far, for what we've gotten, we've had some pretty rigorous things to explain back.
Right.
Here's what we're doing.
Okay, the last question, and then I think Matt's going to carry us out. We'll just start, Dana, at your end, and we'll go right down. One change at the state or federal level that you think would most advance learning around effective value-based payment. What's the one thing to change? I put her on the spot. It gives you guys time to think about it. So. Think about your state level. What could the state do? What's the thing the state could do to?
Well, I'm going to cop out a little bit and say what our state has done that I think other states could learn from. And that is that in 2012, the state passed a law that put a cap on how much health care could grow for any payer and any provider system, and tied it to the state's economic growth. So our number's 3.6%. So what that has done is had brought enormous accountability around costs for individual payer organization and provider organizations around controlling the rate of growth in healthcare spending, which is really important, particularly given that we all understand that one of the things that's driving consolidation, only one, but one important one, is payment reform, right? You have to have some scale to do the stuff we've been talking about for the last hour. And so I, as a payer, would be pretty afraid of that scaling coming to the negotiation table if I didn't know that the providers in my state were held to the same requirement that I am, not to have their growth in spending exceed the state economic growth. So I would put that out there as
Great.
things for other states to consider.
Something that looks like global budgeting, but we can't use that word. Okay.
I think
one thing.
One thing, I think Medicare and Medicaid have to be on the same page. I know it's hard for the federal government, it's hard for states, but I think what we and the next administration really need to work on are some ways that states could help drive payment reform on a statewide basis, and in partnership with Medicare, greater alignment. I think if we could figure that out, I got it figured out in Vermont, but if we could figure it out in other states, I think that could be very powerful. And I think you'd see, not only do I think you would see the moves to value-based payment happen faster, but I think also for those states that have held out on the Medicaid expansion, if we could find a way to use the Medicaid expansion and the move to value-based payment as a way to make Medicaid programs even more cost-effective, I think we could get millions of more Americans insured.
Easy peasy. Patrick, one thing you could do.
I agree on the state-federal alignment. I think we've made more positive delivery system reform in the last 3 to 5 years in U.S. history. My
Yes.
first boss, Don Berwick,
Yes.
said that. I think we got a lot more work to do. I think in addition to the state-federal alignment, I think it's actually courage and alignment across stakeholders, and it's courage, also you alluded to revenue out of people's pockets. It's courage across stakeholders, payers, providers, states, politicians, patient groups. It's a long-term journey, and I worry that we may take a step backwards if we lose that courage to push forward.
The urge for short-term results. It didn't work, move on to the next. Yeah. Okay.
Well, first of all, I agree with Jason's comments, very much so. But I think that if I focus perhaps on the Medicaid population, I'd say one of our biggest barriers is data sharing with social services. That to break down those barriers would be very helpful to us.
Please join me in thanking these guys for a great session. And thanks for the work that they're doing to advance this, but also for the work that all of you are doing in your states. Matt.
Thanks.
All right, thank you. Don't leave just yet. A couple quick announcements. So I really appreciate everything that we've heard up here. You know, this issue has kept 1,000 people in their seats, although now they're starting to go. Thank you guys so much. This is great. Thanks, Jason. This is one of the key issues that we're going to be facing as a country, as states, as Medicaid programs, as an association. So we're going to continue our fight on this, and I think a lot of the things that Jason was saying about keeping these issues, the state-federal alignment at the forefront of thinking about transition plans is critically important. That's something that we're going to be focused on as an association, and I'm glad that Dr. Conway was here for that because he's going to be kind of the transition guy. He's the highest-ranking career official at HHS, so this is it's a good audience and it's a good person for us to be engaging with on that actual question. So let me give you a couple of logistic things. We're going to take a quick break, take a 30-minute break. The next set of breakouts are going to be at 4:15. We're going to do MACRA, MMIS, justice-involved individuals, and dental. And then we are going to be having another happy hour, so I hope you can join us in the exhibit hall at 5:45. And then tomorrow morning we are here at 9 o'clock for our opening Election Day plenary, which is with a healthcare futurist looking at the future of Medicaid and the healthcare system. So thanks everybody, and keep fighting the good fight.